Good morning, and welcome to the Enterprise Costing Work Group. My name is Lindsay, and I am joined today by my fellow project team analysts, Elizabeth, Shiva, and Matt. As you know, we have been working with Dr. Mira and Dr. Waters to analyze the current costing system here at Boston Children's Hospital. Over the next 15 minutes, we will share the results of our findings and offer our recommendations for how Boston Children's Hospital can move forward with appropriate bundled pricing. At the end of our presentation, we will be happy to answer any questions that you may have. This five forces analysis indicates that hospitals are a moderately profitable industry. In addition, research indicates that average operating margins are around 10% for most for-profit hospitals, compared to 26% for biotechnology and 7% for health insurance. Competition among hospitals is fairly localized, either to a specific metropolitan area or a particular submarket, and reputation is an important factor. 2 decades ago, most hospitals were independent, but through significant horizontal and vertical consolidation, many now belong to hospital systems. Decreased fragmentation allows hospital systems to focus on coordinated care and increased quality for patients. It also means that there are often just a few large players that command a majority of the market share. Current industry trends point to significant increases in bargaining power of both suppliers as well as buyers. At least 9 medical device companies have added new surcharges or warned hospitals of price increases to cover the new 2.5% federal medical device tax. Although hospitals sign contracts with these companies, it may be difficult to spot cases where device companies raise prices without explaining it on the bill. Using their regulatory power, government payers such as Medicare and Medicaid have lowered their reimbursement rates and changed their rate structure from fee-for-service to pay-for-performance. This is where the concept of bundled payments comes in and will be discussed later in this presentation. Through consolidation, such as the companies that are shown on the board, insurance companies have been pressing hospitals for discounts of 5 to 20% lower than rates hospitals usually get from other commercial plans. By accepting less reimbursement from the insurer, hospitals are banking on increased volume of patients. Insurance exchanges will be driven by price, so insurers are trying to put together the lowest price option. In the consumer-driven model, consumers occupy the primary decision-making role regarding the healthcare that they receive. This gives people greater control over their healthcare and allows them to compare quality and costs and negotiate lower prices. So what does all this have in common, and how does it affect us in the hospital industry? We as hospitals are now facing increased price pressure from all sides, but especially from buyers who have very high negotiating power. We simply cannot sign long-term contracts and give 20% across-the-board price cuts without first understanding how much it costs us to provide that care. Otherwise, no amount of increased patient volume is going to make up for negative margins.
So in light of this shift in power in the industry, we recommend that BCH take a three-pronged approach, and this consists of using bundled pricings for their service, more accurate models for estimating costs, and as well as quality improvement measures. It should be noted that all of these together must be implemented at the same time. Any one of these alone will not be sufficient to keep Boston as profitable and as reputable as it is right now. So there are benefits and there are negatives to both to bundled pricing. So some of the negatives are that it actually does take the risk away from the healthcare insurers and shifts it toward us. And this can be a problem because we can risk cost overruns. This is why having more accurate costing estimations is critical for this plan. But the benefits are really great, not only for Boston, but also for our industry. By switching to these more value-based reimbursement plans, we are better aligning the incentives throughout the healthcare industry. Better aligning these incentives means that we won't sacrifice the quality of care for price, so that we'll be able to remain profitable, but continue to strive to find these quality improvements that are successful. No longer will the firms or doctors who are using cost-efficient methods and who are coming in at lower costs be penalized for lower revenues because they can't price out as much for their service. So here we see a representation of how a pricing model should work. Currently, the costs in the system do not reflect this. We don't have a way to accurately measure these costs, so there's no way for us to accurately price what it costs to provide these services. Generally, there are two different types of ways we can price different products or different services. We have value-based and we have cost-plus pricing. Value-based is a system where we go to the competitors or we go to our customers and we look at the benefits that we are offering and we base our price off of what the market values these benefits for. For cost-plus pricing, we have an accurate model of how much we actually incur as far as costs to offer these different procedures or products. And then we apply a margin, and then that is the cost we arrive at. This cost plus pricing is going to be the most efficient way for us to price in this new system under bundled pricing.
All right. Now let's look at different costing schemes that were based on the data that was available to us. Firstly, you have RCC, which is the ratio of cost to charge. Then you have RVU, which is relative value unit. And lastly, we have TDABC, which is time-driven activity-based costing. You can see some pros and cons on the slide up there. Green, generally, we've used green to denote pros of a certain approach. As you can see, that TDABC takes more time and is harder to implement, but that's because it doesn't make any assumptions or any arbitrary calculations as the other two approaches, which is RVU and RCC. Let's discuss the benefits of TDABC in more detail. In TDABC, we have better allocation of research costs. They should not be included in the cost of the procedure, and they're shown separately, which is a great thing. Secondly, you've got more objective allocation of overhead. It's important that overhead in any organization is allocated appropriately. TDABC does a great job of that. Thirdly, treats excess capacity costs as separate. Whatever resource is not being used, whatever capacity is underutilized, the costs are treated separately, which is important. Lastly, process mapping of treatments is done efficiently. To see more to see a little bit more detail about what process mapping is about, the figure the figure on the screen will give you a better idea of what a process mapping for TDABC would be like. As you can see, a large process is divided into sub-processes. Each of these sub-processes are measured. Based on the time taken by each of these resources in the sub-processes, a total cost is calculated. This, like I said before, is harder to implement. It probably consumes more time to implement, but gives you the best depiction of what a cost for a company should be like. We went ahead and did some calculations based on the data that was available to us. The yellow line represents reimbursement. The green shows the cost based on RVU and RCC schemes, and the blue tells you about the cost as per TDABC. The reimbursement seems higher in plagiocephaly and neoplasm skin excision than the cost, but in craniosynostosis, the actual costs are much higher than what is shown by RCC and RVU methods, and therefore the hospital is making a loss. The reimbursement is not covering the cost. Hence, we're not able to determine the right cost and hence not able to price accurately. Let's look at another example. We have the cast room example. As you can see in the first case, the reimbursement is more in all cases, but in the last case, in the third case, it does not tell you how much profit you're making. The hospital is making a great amount of profit because there's a huge difference between reimbursement and the real cost. That's not being accurately depicted by RVU and RCC.
Not only will going over to TDABC and bundled pricing help us more accurately align our reimbursement with our costs, it's also going to help us on the second key area of improvement that we see for Boston Children's, and that is quality improvement. And most of this stems from the fact that TDABC requires very accurate costing or process mapping. Process mapping will allow us to determine where there are inefficiencies in our care procedures, as well as where we're deviating from clinical guidelines. This will allow us to change our processes so that we're providing the best possible care for our patients. But simply identifying these areas is not enough in order to see patient quality improvement. What we need is these areas to actually be fixed. The first way to do this is through the bundled pricing system in general. Because each unit of our hospital will then be receiving a fixed reimbursement, the unit directors and the employees under them will have an incentive to try to streamline these processes as a way to maximize profit for their particular units. The problem comes, however, with physicians who are not employees of the hospital. How do we get them to buy into this system of changing our care processes so that they more closely align with clinical guidelines that give the best possible patient outcomes? And that's where pay for performance comes in. First, to start off with the current situation for compensating physicians, they're currently paid by the health plans. And under bundled pricing, they will now be paid by Boston Children's, who is receiving a bundled payment from the health plan to provide all services. We recommend that for the time being, Boston Children's keep the same type of fee-for-service compensation for the physicians of Boston Children's Hospital Physicians Group, so that there's not too many changes at one time. But on top of this, we would recommend a 5% pay for performance option. Pay for performance generally has 3 key areas: structural metrics, process metrics, and outcome metrics. And so now we're going to go into some more detail on those. With the bundled pricing in TDABC, the 2 key areas will be the process metrics and the outcome metrics. Process metrics will become very obvious once we've done process mapping, because we know what the current care delivery model is and what clinical guidelines say is the optimal care delivery model. So comparing those with the help of electronic medical records will allow us to determine whether physicians are following the best practice guidelines and give them bonus payments accordingly. And the outcome measures will also be important because it is outcomes that affect our profitability under bundled pricing. If we can improve our outcomes, we will lower our costs because we aren't treating patients who run into complications, thereby maximizing our profit. So we would recommend teaming up with physicians to determine the best metrics to use for pay for performance, but focus on the outcomes and the processes. Doing this will be able to allow Boston Children's to offer a very enticing value proposition to both payers and consumers. Payers like the bundled pricing because it shifts risks away from them, and customers like the fact that they're getting higher quality care. Nobody wants to stay in the hospital longer than they need to. Nobody wants to receive a lot of unnecessary tests. And bundled pricing gives Boston Children's the incentive to provide just that type of care. So moving forward, we recommend that Boston Children's continue with the process mapping of other areas of the hospital. This will be a very expensive and time-consuming process. However, we think that the benefits from more accurate costing and identifying areas for process improvement will make it worthwhile. Secondly, we need to get buy-in from physicians and other hospital employees, or else implementing these massive changes will not be feasible. Therefore, we would recommend collaborating with these groups throughout every step of the process, receiving input from the physicians group so that they are on board, they know what changes are happening, so everyone is on the same page. And we think that if we're able to do this, then Boston Children's will be at the forefront of care delivery in the Boston area. Thank you.
I have a question and a comment. My comment is a well-prepared presentation, very on point. But I want you, if you can, to and any member of the presentation group can address this. There's a strategic issue that I'm still a little bit confounded about, and I'd like to know how you have addressed it, and what you anticipate as a second-order effect. I noticed from the material at hand that Tufts Medical Center and their pricing structure in many ways, is what has compelled Boston Children's Hospital to take this initiative, to find a better way of developing a pricing structure. And rather amazingly, as a floating hospital or a hospital within a hospital, Tufts apparently, their cost structure results in about 50% less in terms of price structure than Boston Children's Hospital. So bundle pricing considered, you're still going to have tremendous competition, because I will assume that Tufts is not going to stand still, and in terms of their approach. So how is this approach that you're recommending strategically going to impact the outcomes?
Thank you for that question. I think that's a very valid point. We need to look at what our competitors are doing and how this fits into that model. I think that with the bundled pricing, one major benefit is the fact that we're going to be improving these processes, so hopefully bringing our costs down closer to what Tufts and other competitors have. It may not be below them. We may be charging slightly higher prices, but that's where the quality improvement side comes in. As healthcare becomes more consumer driven and customers have more of a say in where they receive care, if we can provide better quality care and better outcomes than Tufts, then even if we're charging slightly higher prices, we should be able to get customers as well.
I agree with George. Wonderful presentation. You all should be very proud of yourself. I have a question now about, let's look at when you're talking about clinical procedures. And of course, when you're talking about costing of clinical procedures, most clinical procedures follow a bell curve. Normally, the cost of most of them fall in the middle part of that bell curve. But you have some that we call outliers, where for some reason they're very, very costly. And in bundle pricing, that becomes very important. What would your recommendation be to do about outliers?
Thank you for the question. You're absolutely right in terms of outliers will cause a problem in any costing structure. But that being said, if you use TDABC, it's not going to be significantly higher than you use RVU or RCC. In fact, you'd be able to better depict each of these costs, and you will be able to price it accordingly. In TDABC, every portion of every resource utilized in that procedure is measured, and therefore you're able to derive into the actual cost of the entire procedure much more efficiently if you use TDABC. Therefore, it would definitely help to use TDABC, and that go a long way in helping outliers.
So you feel that the costing method would allow you to cost out the outliers?
Yes, it'll help us get the more accurate costing of the outliers and therefore price it better.
And then what would you do with that information? I'm
sorry, come again?
What would you do with that?
I would use that information to price it efficiently and make sure that you don't have as many outliers as and strategically you can have less number of outliers. If you're not able to cut that down, you'll have to make sure, for example, there are things such as loss leaders in business. You have one procedure which costs more, maybe you can take a loss in one procedure if you can improve the profitability through other procedures. So.
Good morning. Your delivery was very well done. Not once did you look at the slides, which is impressive because that means you were in sync. You knew exactly what was going to be up there at the time, so I commend you on that. As you know, bundled pricing differs for each of three parties, HMOs, hospitals, and physicians. So what are the key features of bundled pricing for physicians?
What type of features are you talking about? Are you talking about specific procedures that physicians do, or bundled pricing for a physician group, or for physicians in the hospital setting?
Bundle pricing as it relates to physicians, specifically.
For physicians who are providing care in a hospital setting where the health plan is compensating the hospital, it would be the hospital then that determines the correct reimbursement scheme for the physician. So that might be fee for service still. In the outpatient setting, in a physician's clinic, then it would be the health plan that is offering a fixed payment, maybe more of a capitation payment for each individual that they're treating. So there's a more direct linkage between the bundled pricing and the care that physicians are providing in an outpatient versus an inpatient setting. The inpatient setting will depend on the specific institution. Does that answer your question?
Thanks. Yes.
I'd like to relate some comments I've heard from your medical staff at Boston Children's Hospital. As you know, any initiative that's undertaken by hospital administration, no pun intended, but will live and die based on how enthusiastic your medical staff is in terms of embracing that initiative. So the comments I've heard in the cafeteria and in the physician's lounge are relative to the special mission that Boston Children's Hospital has. I mean, we're known for our teaching, research, cutting edge in every way. We've never really considered ourselves as a business. We're here to take care of patients, and many of them are underserved to begin with. So how are you going to address the combined medical staff in terms of making a case for moving to this methodology when we know that we're different at Boston Children's Hospital in terms of our teaching and research? We're not like Tufts, for example.
That's a great question. And that's actually an integral part of why we want to keep Boston Children special and why we think this approach will actually work out very well. Like I said earlier, like bundled pricing is important, but it must be taken in conjunction with this TBAC cost approach. And what TBAC will allow us to do is actually to break down the efficiency rates of our doctors. So by looking at how much they're actually being utilized, we believe we're going to be able to find underutilization, which then could actually be diverted to either improving total offered care so that we could actually bring more patients in, or it could be devoted to either training or research areas. By actually knowing how much time the doctors are spending in each different process, we are going to be able to see where they're being inefficiently used. And this will increase the overall efficiency throughout the entire system. So this is one approach that we feel like we won't be able, or we won't have to sacrifice the quality that we are able to give, and we won't have to sacrifice research or training.